think the biggest thing is having confidence in just seeing what you're seeing and being able to diagnose and then treat and effectively manage. Because most of the ocular emergencies that we see, some of them require drops, some of them require procedures, some of them require something else being done, but some of them require a referral out. So it's not only can we see it, but can we effectively get them to where they need to go, whether that's prescribing a therapy or sending them to a primary care, a retina surgeon, or somebody else that needs to take care of that now, that has the surgical tools to do so. It really does depend what you're seeing and what you're looking at. Like anterior segment issues, a lot of times we can treat for that. A lot of times we can take care of that. And then if we see something change, then we're referring to a specialist to kind of help. If it's something in the retina where we're worried about vascular disease or tumor or some sort of space occupying lesion, those obviously require somebody else to take care of that. When we're worried about stroke or high blood pressure or vascular accident, a lot of times we need to send that to an ER or primary care and get in communication so we can get them the care that they need at that moment. I mean, they come in waves. Like, it's so crazy to me to think that, like, some weeks I'll go without seeing somebody that's like a true ocular emergency. Some months I'll have 2 to 3 to 5. It really just depends. It's all cyclical, but I think the biggest thing is seeing those urgent care visits and asking and advocating for your patients to think about their optometrist as their first stop rather than an urgent care or somebody else like a doc in the box that isn't an eye care provider, so that we can go, hey, I'm your first line of contact with redness, sensitivity to light, vision pain, vision changes, or pain. I need to be your first point of contact because I'm going to know where you need to go faster than maybe some other physicians. The thing with scope expansion is that it allows for us to take a wider care of patients, but we still have patients that we see that need other care. So I think it just makes us more alert to the things that we can do to help intervene. But a lot of times these patients still need referrals out, still require multiple doctors in order for us to alleviate what the underlying issue is, whether that's a vascular incident or whether that's an ocular emergency. There's a lot of different things that we need to be able to calculate. And the doctor who's on top of scope expansion is probably going to be somebody who is more comfortable doing that than somebody that is not necessarily as concerned with scope expansion. There's a saying in eye care, which is it's not rare if it's in your chair. So all it takes is one patient to have something to be in your office for it not to be rare. Taking those urgent cases and making sure that we are seeing them in an appropriate and timely manner is super important to patient care. It's important to protecting patient sight and vision and protecting their eyes, which is something that's so valuable to them.